Hello, everybody. Whatever your location is, I think we've got an international audience. My name's Alistair Roth. I'm the Executive Director at AII Victoria. Welcome to our second live webcast. This is one of the ways we're trying to engage with our community while we can't run our usual face-to-face speaker events, and we really appreciate your interest. Just a brief word on the running order. After this, the main presentation will go for about 30 minutes. We'll then do a Q&A session for about 20 and aim to finish at 10 to 6. We're going to be using the little Q&A tab in the toolbar at the bottom of your screen. You can type a question in there. Please try to keep it brief, but you can also vote on questions that anyone else has asked. So Tuesday this week was World Health Day, and we really wanted to cover a health-related topic. We're really fortunate that we've been able to arrange for Professor Adam Kamradt Scott to talk about health security policy and politics. Now, Adam may be well known to a lot of you. He's certainly been in demand with the press over the last few weeks, but he's an expert in global health security at the Centre for International Security Studies at the University of Sydney. He's got a really interesting background. He's been a registered nurse, a public servant. He's been a political advisor in Prime Minister and Cabinet, where he was part of the team tasked with revising, testing, and updating Australia's pandemic plans. How prescient was that? His research since then has been on wider global health security and international relations issues. I don't know quite how he's managed to make time in his schedule to join us today, but Adam, we're really pleased to have you with us. And right now, I'll hand over to you in Canberra.
All right, thanks so much. That's a very kind introduction. Hello to everyone online. So I'm just going to share the screen here and we can get started. So I wanted to first cover off some of the aspect with regards to the science around coronaviruses, because I think it's really important to first understand some of the science before we then talk about the public health response and the politics around something like a disease outbreak or a pandemic as we're currently facing. So with the coronavirus, it's important to appreciate that we have had a couple of novel coronaviruses that have emerged over the last 20 odd years. The first and most prominent one of those that most people will probably remember was the 2003 SARS outbreak, which arose originally in China and which then spread further afield to around 29 different or 32 different jurisdictions. In addition to that, we've had the emergence of the Middle East respiratory syndrome, which emerged in 2012 and has also started to, it's also circulated the globe, but hasn't had the same level of impact, principally because it is not as easily transmissible. And then obviously now we have the 2020 pandemic, which has been initiated by a novel coronavirus as well. Novel coronaviruses are quite common though, and what we find is that they are usually responsible for the common cold. So sometimes, and oftentimes in fact, when people come down with an influenza-like illness, unless they're actually laid out on the bed for around a fortnight, the more likely culprit is actually a coronavirus. And it's quite common that these will cause common sort of respiratory symptoms, very similar to influenza, but it's not as potentially as severe. Obviously, the challenge with the current outbreak is that this is actually much more severe than your regular influenza. What we found from previous outbreaks is that the host organism where this virus resides has actually been in bats. So we've traced it back to bats with both the 2003 SARS outbreak and then as well as the 2012 MERS outbreak. But importantly, in both of those outbreaks, there was an intermediate host animal as well. So in the case, for instance, with MERS, the host animal was actually camels, and it's the bats ended up infecting the camels, and then the camels passed the infection on to humans. And that's why you may have heard some speculation and focus at the beginning of the COVID pandemic. And we've heard, for instance, that it may have emerged from snakes or it may have emerged from pangolins. That intermediate animal hasn't been identified yet with COVID-19, nor has the host organism. So that's really important, and work will have to continue on with that to identify what the host organism is and if there is an intermediate animal, because without identifying that, obviously there is the risk that once we get the current pandemic under control, we might see another outbreak of it. In each of these instances, what we've seen, the transmission of the coronavirus has been firstly by droplet form as well as fomite. Now, fomite is a technical epidemiological term, which basically means inanimate object. So it's not trying to confuse you, but you might hear that referred to in the press. And I just need to apologise at this point. My puppy is over in the background making some snorting noises. So if you hear that, it's not me, it's just my puppy. So going back to transmission though. So the main way in which this is spread is through droplet and inanimate objects. And in particular, if people cough and sneeze into their hand and then they open a door, then the virus will survive on the door handles. And what we know now from studies that have been done with COVID-19 is that the virus will remain viable on both plastic as well as stainless steel for up to 72 hours outside of the human body. It survives on cardboard for around 24 hours, but is not really infectious after about 8. So, and it's on copper, it's even less. It's a maximum of about 8 hours that it remains viable. We have also seen, and this was a big factor which helped spread the SARS and the MERS coronavirus previously, has been as a result of when people present to hospitals with acute respiratory distress. One of the first medical interventions usually that happens is that we put people on nebulized Ventolin, which is a medication designed to open up the airways to help people be able to breathe more. But the process of that medical procedure basically aerosolizes droplets of the medication, which people then breathe in, and then they also breathe out. And it's been in that process of the aerosolization and what people then breathe out, which we saw contribute particularly in the first instance to the spread of SARS in 2003, but also with the outbreak of the MERS coronavirus in 2015 in South Korea. So that was a big factor. But there's an important distinction here. The aerosolization only occurs as a result of medical procedures. We don't have evidence at the moment that this virus is actually spread through respiratory form, like we have with things like influenza or measles. So it's droplet or fomite. The most common symptoms, an initial presentation with COVID-19, based on the data that we had out of China, is around 90% of people will develop a fever or an elevated temperature in the first instance. And around 70% of people then will also develop a dry cough. What we've seen after that is that, and around 80% of people, that's effectively the amount of illness that they will exhibit. So for many people, this will seem like a common cold type arrangement where you end up with a temperature, a bit of a dry cough, but it doesn't really progress further from there. Based on the data out of China, what we've seen is that around in 20% of cases, people will develop a more serious form of illness. And that may include leading to things like shortness of breath, and around 6% of people may develop a severe form of pneumonia. There is what we've also witnessed, though, that was based on the data out of China. What we're also witnessing is in other countries, these numbers can be slightly different. So we also have heard a fair amount about the fatality rate of COVID-19. And so I wanted to sort of talk about that very briefly as well. With the SARS coronavirus, the case fatality rate, which is the number of people who die divided by the number of cases, it was around 10%. So there was 8,098 cases of SARS coronavirus and 774 fatalities. So it was around 1 in 10 people that got exposed to SARS died as a result of their exposure. With the Middle East respiratory syndrome, we've seen that much higher. It's around 35%. But the MERS coronavirus hasn't achieved the effective human-to-human transmission that COVID-19 has had. What we've seen with COVID-19 is that the case fatality rate is varying quite extensively. Now, there's a number of factors which may explain this, including a lack of testing in some areas or countries, whereby the presence of the virus will be much higher. And so all you're really sort of seeing is when people become very sick and die, versus other countries that have put in place widespread testing, which have then been able to identify a lower case fatality rate. Having said that, what we're seeing is a fairly extensive variation across countries. So with Australia, our case fatality rate is currently around 0.5%, which is around 4 times higher, around 4 times higher than seasonal influenza. Whereas countries like Italy have recorded a case fatality rate of between 9 to 11%, based on the figures that they've identified so far. So things are obviously very different from country to country. What is likely to happen is that over time, we will get a much clearer sense as to what is the more accurate case fatality rate as we're able to do more testing and we're able to identify the people who have been infected and those who have then gone on to develop more severe illness. So I think it's important to understand the politics of some of what's happening now for us to go back and actually have a little bit of a look at the 2003 SARS outbreak, because that helps explain some of the politics of what's occurring. So we now know that the SARS outbreak, the SARS coronavirus was circulating in China for up to 2 years prior to it initiating an outbreak in November of 2002. And the way that we know that is that the Chinese authorities have gone back and tested their antibodies of people from blood samples, and they have detected the presence of the coronavirus up to 2 years prior. But importantly, while it was circulating, it obviously hadn't initiated a major issue until November of 2002. And at that point in time, there was a large cluster of cases that were identified in Guangdong province in southern China. And this cluster of cases was actually detected by a online tool that is constantly scanning the internet for news about disease outbreaks. When it was detected, the World Health Organization was notified, and they then contacted the Chinese authorities and said, look, we've detected this anomaly from reports that there is an outbreak of some sort of atypical pneumonia in southern China. Can you please confirm? And the Chinese authorities declined to or denied that there was any problems. A further report was then identified again in December of 2002, and the WHO again approached the Chinese authorities, and they again declined to announce that they had an outbreak. It wasn't really until February of 2003 when a large cluster of atypical pneumonia was identified again in Guangdong province, and there was 305 cases. And in this instance, the Chinese authorities confirmed that there was a cluster of cases of 305 atypical pneumonia, but there had been only 5 deaths, and the situation was under control. And it wasn't then until a doctor who had been treating patients in Guangdong province decided to attend his nephew's wedding in Hong Kong with his wife. And so he travelled from Guangzhou over the border to Hong Kong and stayed in the 9th floor in the 11th room of the Metropole Hotel, which you can appreciate then gave rise to a number of conspiracy theories about what really happened with SARS and who was behind it. But nonetheless, unfortunately, the doctor inadvertently passed the virus to 16 other hotel guests during his overnight stay. He ended up being admitted to hospital the next day due to his condition deteriorated, and he subsequently died. We still don't really know exactly how the doctor passed the virus to 16 other hotel guests, but importantly, 14 of them were overseas travellers. And I can come back to some of the hypotheses around how that may have occurred, perhaps with questions and answers. But 14 of those hotel guests that were infected then ended up boarding planes the next day and flew to various different destinations. One of those travellers was an American businessman who flew from Hong Kong to Vietnam, where he then, on arrival, recognised that he had developed respiratory distress and presented to a hospital, where there was an Italian epidemiologist by the name of Carlo Urbani that was working in the hospital there. And Carlo Urbani identified that there was, what he noticed was that a number of the healthcare workers who ended up treating the American businessman also developed similar respiratory symptoms. And when they tested for the presence of influenza, they found no influenza. And so Carlo Urbani ended up then alerting the World Health Organization, the organization that he worked for, to the fact that there may be a novel virus which is causing respiratory distress. And that was really what put the world on alert to the presence of the SARS coronavirus. Unfortunately, Carlo Urbani died. He ended up getting exposed himself. And it was his death which then prompted the World Health Organization to really publicly come out and criticize the Chinese government for trying to hide the nature of the outbreak. In 2003, SARS then was identified in spreading to a number of other jurisdictions and territories. And it wasn't until 2003 in July, the 4th of July, I believe, in 2003, that the SARS outbreak was ultimately contained. The final jurisdiction to contain the coronavirus was Taiwan. In April 2004, we had some laboratory cases of scientists that had been working with the virus in laboratories who then ended up contracting the virus. But the last one of that was in April 2004. So the SARS outbreak is widely considered by many public health people as a wake-up call for the international community. And it certainly was the case that it caught the attention, particularly of high-income countries around the world, because it was the first time we really saw with stark contrast how easily a virus could spread globally via international air travel. And this then prompted or gave further impetus to finalising the negotiations on the international health regulations. So the international health regulations were first adopted in 1951, and they subsequently went through a series of revisions. They ultimately were substantively revised, though, in 2005, largely on account of the experience of the SARS outbreak. And it's that framework which we now have, which is sort of operating and providing guidance when we see disease outbreaks and public health emergencies. Beyond the finalisation of the IHR regulation, the finalisations of the international health regulations, though, we also saw that SARS had a number of unintended consequences. I've already mentioned the human cost to this, which was around a 10% fatality rate. But importantly, SARS was actually quite difficult to contract compared to, say, influenza. And it was the result of the virus being transmitted through medical aerosolizing procedures, which actually contributed to some of the high burden of morbidity and mortality that was experienced, particularly amongst healthcare workers. Having said that, the SARS outbreak, and this is why it kind of caught the world's attention as well, particularly high-income countries, was estimated to have caused around $30 billion worth of economic damage in 4 months in Asia and up to $100 billion globally. We also saw that there were huge impacts socially. So occupancy rates in places like Hong Kong went from around 85% prior to the commencement of the SARS outbreak down to between 5 and 10% at the height of the outbreak. It ended up prompting widespread social distancing practices. And we saw, for instance, in places like Japan and Hong Kong, people were employed just literally to decontaminate the handrails of things like escalators to try and prevent people being exposed as a result of putting their hands on escalator rails. We also saw widespread use of quarantine, and that was ultimately what defeated the SARS outbreak, because we weren't able to get a vaccine in time, and we still don't have a vaccine for the SARS coronavirus. It also was noted to have a large number of psychological impacts. And here it really has to be, I think it's really important for us to, again, still acknowledge, even 20 years on, the sacrifice that many healthcare workers paid. There were very tragic stories about how doctors and nurses in places like Singapore would, rather than go home, they would drive past their home in their cars and wave goodbye to their families, rather than run the risk of, and then they'd drive back to the hospital rather than run the risk of exposing their families. And unfortunately, a number of those healthcare workers died as a result of their exposure. Perhaps one of the more significant implications as well was the political consequences which arose as a result of the SARS outbreak. And in particular, we saw instances where government authorities were held to account by the standards that the WHO, the World Health Organization, had set. And in places like China and Hong Kong, we saw politicians being removed from office. In Singapore as well, there was a lot of criticism about the government's use of what was described as draconian measures. By contrast, Vietnam was widely praised and held up as the poster child for its prompt handling of the SARS outbreak. And as a result of that, while a number of countries such as China, even Canada, ended up with travel advisories warning people from traveling to SARS-affected areas, Vietnam, even though they had ongoing rates of transmission, did not end up receiving a travel advisory from the WHO. We've seen a slightly different picture, though, with the MERS, or Middle East Respiratory Syndrome. So the fatality rate is much higher than SARS, but it's still, we haven't seen it spread as further afield and as wide. And probably the closest we got to that really was the outbreak of the Middle East Respiratory Syndrome in South Korea in 2015, where there was 185 cases that were generated largely as a result of that medical procedure that I was talking about earlier, the aerosolization of Ventolin. But they were ultimately able to get that under control. We haven't seen the economic consequences as widespread from the Middle East Respiratory Syndrome either. Now, there's several factors for this. One is that we haven't seen that widespread transmission. We have seen cases appear in a number of Middle East countries, but we haven't really seen it further afield. Having said that, obviously, the other aspect, we haven't also seen travel advisories being issued by the WHO, and we haven't really seen other countries react by putting in place import or export bans on the MERS-affected countries. Having said that, South Korea's economy was estimated to have taken a hit of around 0.7% GDP as a result of their experience with the 2015 outbreak. We also haven't seen the impacts in terms of tourism and other types of major changes that we've seen with the Middle East, with the SARS outbreak in 2003. And there's been a lot of speculation that this is because we haven't seen things like the travel advisories being applied against countries like Saudi Arabia, Oman, and many other sort of Middle East countries that were affected. We also haven't seen the major political consequences. I think the closest that we got to that was whereby Saudi Arabia's deputy health minister was fired during the outbreak in Saudi Arabia, and unhappiness with his handling of the crisis. It has raised also a number of political issues, particularly with regards to organisations that are able to then patent elements of the virus and thereby sort of try and gain financial benefit. And there was the particular case of Erasmus University's entity, which ended up patenting the MERS coronavirus, or elements of it, which meant that any diagnostic tool that was developed, then they ended up getting royalties for. So what about the current pandemic? Well, this outbreak, we now know again that the virus was detected or was present circulating in the community around November of 2019. And some of you may have noticed a report from CNN today noting that US intelligence officials confirmed the presence of the virus circulating in Wuhan in November. But importantly, the WHO was not notified by the People's Republic of China of a cluster of cases of pneumonia in Wuhan until the 31st of December. Then, though, the Chinese authorities did move rather rapidly to confirm that it was a novel coronavirus, and when they did confirm this on the 7th of January, they also released the full genome sequence for the virus at the same time. So that just goes to show how things have changed progressively in technology since 2003. It actually took scientists a number of weeks working around the clock 24/7, sharing their data internationally on virtual platforms before they were able to map the genome of the SARS coronavirus. And the Chinese authorities were able to do it within the space of a few days and confirm the presence that it was a novel coronavirus. The WHO alerted the international community to the presence of this cluster of cases of pneumonia on the 4th of January, initially by social media, but the next day they sent the news around via the disease outbreak alert network that they run. 13th of January, we saw that Thailand reported its first case, and this was the first case to be detected overseas or outside of China. Obviously, Chinese authorities reacted and responded to the spread of COVID-19 in Wuhan by closing down Wuhan and much of Hubei province, effectively putting around 63 million people into lockdown. On the 23rd of January, the World Health Organization convened the international health regulations, and under that framework, there is an ad hoc committee which can be created called the Emergency Committee. And this is a committee comprised of technical experts. It's assembled on an ad hoc basis, so membership is not fixed. They select members on the basis of their expertise, and the members met over a 2-day period to review the data that was emerging out of China, and decided that there was not enough evidence yet to declare what is described as a public health emergency of international concern. And this was a particular sort of new mechanism to alert the world to a public health crisis, which was adopted under the international health regulations. So it's kind of an alert level for WHO to utilise to say, look, we've got an outbreak here and it's of significant concern. But the committee basically recommended to hold off declaring a public health emergency of international concern at that point. However, within the week, they met again, and on the 30th of January, they then recommended that the Director General declare a public health emergency of international concern, which he subsequently did on the 30th of January. On the 11th of March, the WHO Director General declared a pandemic, largely on account, by his own explanation, because they were concerned that a number of countries had not used the time productively to prepare for the arrival of the coronavirus into their territories. And a number of countries do have their pandemic plans basically matched with a WHO declaration. And so this declaration was seen to help enable countries that hadn't yet enacted those pandemic plans to do so, while really encouraging the rest of the world to pay attention to this crisis and make sure that systems were in place to try and manage the inevitable arrival of cases. As of today, the coronavirus has now been detected and confirmed in 184 countries around the world. This morning, there were reports that the number of cases had exceeded 1.5 million cases, but looking at the database this afternoon, it's dropped back to 1 million, almost 1.5 million, but obviously just shy. We have had, though, now almost 90,000 deaths as a result of this virus. So it's a very different beast from the SARS outbreak. It's even more of a different beast from the Middle East respiratory syndrome. And this is arguably an ongoing concern. So what have been some of the politics that have arisen around this? WHO had actually advised against any countries putting in place travel restrictions. Now, this is fairly consistent practice with WHO in the past, based on previous outbreaks. But what we saw rapidly was that a large number of countries basically ignored those temporary recommendations and moved to institute either full travel bans or put in place travel restrictions against certain areas and countries. That is going to be something which we are going to have to return to after the pandemic is over, and particularly when we're looking at things like the international health regulations and what it means for the future, given that it would appear now that a number of countries that did institute these travel restrictions and travel bans actually helped to delay the arrival of the coronavirus. And yet this is something that historically the WHO was warned against, principally because it creates economic problems to compound a public health crisis. And we've also seen, as a good example, during the Ebola outbreak, when countries put in place travel restrictions and flight bans and flight cancellations, it actually impeded the ability for public health workers and healthcare professionals to get to and from the affected countries to help them respond to the Ebola outbreak. So that's just one reason why the WHO has historically advised against putting in place travel restrictions. We've also seen the WHO Director General criticised for praising China's efforts, and it was announced overnight that he has also received death threats over the past 3 months, which is arguably unwarranted and obviously despicable behaviour on behalf of those people that are engaging in this. But there have been concerns that that the WHO was effectively in China's pocket, and that they were heaping far too much praise on China. We can come back to that, though, perhaps in question time, as to why that Director General was making the comments that he was. And it's probably just important to appreciate there's a very fine line here that he was trying to tread. One of the things that we've seen, obviously, the utter human tragedy that's unfolded in countries like Italy and Spain and France, and increasingly what we're seeing in the United States. One of the big concerns really is what happens when this virus hits low-income countries, not only throughout Africa, but also our region as well. Those countries that don't have advanced healthcare systems, they may not have universal health cover, and importantly, they also don't have the diagnostic laboratory capacity to even detect for the presence of the virus. And if what happens in countries like Italy happens in low-income countries, then this is going to result in millions of deaths. We've obviously seen the global economy come to a rapid halt. And there's been a lot of comparisons being made with the global financial crisis of 2008. But importantly, it's likely that this is going to be much more significant. It's going to be much longer and much deeper. There are obviously people already talking about the fact that this is going to generate a new global depression, which is obviously not ideal. And so there's a big focus, obviously, on trying to get countries back into normal social and economic functioning as soon as possible. One of the more disappointing elements, I think, for me personally, has been that over the last 7 odd decades, we have progressively worked to recognise that when we are confronted with a collective security threat, that we would have mechanisms in place to respond to that threat collectively as well. What we've tended to see with the current pandemic is that countries have instead turned inward and focused very much on controlling their own domestic epidemics, which is completely understandable and appropriate. Equally, though, we haven't yet seen that sort of global solidarity emerge. And normally we would look to countries like the United States to really lead the effort there. And of course, with the current president, that does not seem likely. And so there is grave concern about what will happen in low-income countries when this virus hits in a significant way. We've also seen politically that aside from the WHO's public health advice, the organisation has been largely sidelined. So countries aren't really, and governments aren't really appear to be willing to listen to the WHO on issues such as travel restrictions and visa bans. But they are interested, obviously, and closely paying attention to, in the event the WHO is able to offer some good insight into what other countries have done to help control the COVID pandemic in their context. And overnight, of course, we've had President Trump floating the idea of cutting all funding to the World Health Organization. This is not really surprising from my perspective. We've already seen that President Trump has a bit of a penchant for trying to rewrite history. And I was talking with some US media this morning and just going through the timeline of the US response. And this is certainly not to gloat or not to sort of cast shade on the US and laud the Australian government's response. But it is rather ironic to me, after many decades of working in this space, that we would look to countries like the United States as leading the way in having all the systems in place to respond to this. And instead, what we've seen has been a country, basically, the systems effectively falling apart, where you've got governors trying to outbid other governors in order to get access to personal protective equipment for healthcare workers. It is heartbreaking to see the US go through this process. And as while there have been a number of criticisms about the Australian government's response and the criticisms and some mistakes that have occurred, I think all we have to really do is look to countries like the United States to fully appreciate how things can really go terribly wrong in the event that we don't have good, solid leadership in a public health emergency. So on that note, I will probably finish it there. You'll forgive me, I am a former registered nurse, so I'm going to try and emphasise some public health messaging at the same time. So cough and sneeze etiquette, really important coming into the winter flu season for Australia, because we are obviously, this is going to be a challenging time for our country, because it won't be immediately apparent given the symptoms whether or not people have got COVID-19 or your regular seasonal flu. So it's really important that everyone practices and personal hygiene practices, and that you are stringent in your behaviour with them. So I'll stop there and hand it over for Q&A. Thanks.
Wow. Yeah. Adam, thank you very much indeed for that. It's let's just show it. Yeah, somewhat sobering, rather scaring, but it's fantastic to hear a measured and scientific approach to all this. So lots of questions, some of them you've covered already, and I'm sure we'll come back to them, and a lot of questions about the shape or the size or the effect on the WHO after Trump. But just a couple to ask first. One of them is, to what extent are the Chinese wet markets and trade in the wild animal trade to blame for this?
Well, that's a really good question. The short answer is we still don't actually have it confirmed 100% that it was a wet market that was responsible. For those of you who aren't familiar with the wet market, obviously, I mean, there's been a lot of talk about it, so I'm assuming most people are, but these are food markets basically where they are live animals and a whole variety of different live animals, which are then sold to people as they move through the market. And we saw that this played a role in the outbreak of SARS in 2003. And there was obviously speculation that it has played a role in the start or commencement of COVID-19 as well. That is based on the fact that some of the first cases that were identified and singled out in Wuhan had a travel history of having shopped in the wet market, and it was a seafood market. But importantly, the authorities closed it down, and they haven't been able to actually confirm the presence of the virus, nor have they been able to identify that host organism either, which may have precipitated this. So it is obviously a concern, and I think it's probably one of the big factors which has certainly contributing to the emergence of new diseases. So around 70% of the new diseases that afflict humans end up coming from animals. And so wherever you've got an environment where people are coming into close contact with animals in that sort of context, then you can obviously see the increased risk of that transmission occurring.
Maybe I can come back as well to the question that there's maybe undue influence of China over the WHO, and you said that the Director General had some issues about that, and also the fact that Taiwan seemed to have done a good job, but they've been kept on the outer because of the political issues around that.
Yes. Well, I might just deal with the Taiwan issue then first, and then I'll come back to the one on the PRC. So for Taiwan, obviously, it is somewhat of an irony in some respects, in that two countries that originally proposed the creation of the WHO was China and Brazil. But China in 1946, when the proposal was first floated, was actually Taiwan, because the KMT, the national government, was basically still in control, and it wasn't, the communists assumed power in 1949. So it was actually Taiwan that proposed the creation of, or the Taiwanese government in the form of KMT, that proposed the creation of WHO. But obviously China and Taiwan held the seat until the 1970s, when China re-entered and re-engaged with the international community, and then they assumed the seat in all of the different United Nations. And since that time, Taiwan has been excluded. There was a lot of concern in 2003 about Taiwan's exclusion, because Taiwan was one of the areas that was affected by the SARS coronavirus, and they have worked and tried diplomatically behind the scenes since 2003 to really sort of progress that. For a time, we have seen the Chinese government allow Taiwan to be present at the World Health Assembly, which is the equivalent of the UN General Assembly, under the title Chinese Taipei, but they haven't been given voting rights. They were just able to make speeches. And importantly, we've also seen that the Chinese government has used this as a bit of a bargaining tool to indicate their level of satisfaction or dissatisfaction with the Taiwanese government in the event of any sort of move towards independence or declarations around independence. So that sort of ability for Taiwan to engage in the World Health Assembly has sort of been offered and pulled back at various different times. It's been rather unfortunate in this instance that I think that Taiwan seems to want to use the pandemic as an opportunity to progress their status. And I think Taiwan has to play this very, very carefully. I think that's been even more complicated by the fact that the Director General called out Taiwan as being behind some of the death threats and some of the abuse that he has received. And obviously that doesn't put Taiwan in paint a very good picture. But ultimately, there's been a lot of criticism of the World Health Organization about its refusal to deal with Taiwan. I think that criticism is grossly unfair. This is actually a UN problem much more broadly. It's not within the power of the WHO Secretariat to grant Taiwan recognition. It is that recognition rests with member states. So if member states want Taiwan included, then it's up to member states to do that. Going back then to the question on China and the WHO. So the Director General, obviously China was publicly heavily criticised by the WHO in 2003, and that embarrassed the Chinese government quite significantly. It's the first time actually that the WHO had done that. They don't have a history of an adversarial culture with their member states, and they've usually tried to be very cooperative and collaborative instead. And so there's been this ongoing level of embarrassment since that time that the WHO Secretariat has been aware that they sort of instigated with China. And I think in this instance, they obviously were quite keen to ensure that China's behaviour for being open and transparent as much as possible at the commencement of the outbreak should be praised and recognised and acknowledged for that. And so that's why we've seen that praise for China. In addition, under the international health regulations, countries now are expected to have these what are described as public health core capacities to prevent the exportation of disease. And so in many respects, the Chinese government, in what they did by locking down Hubei province, actually was doing the right thing under the international health regulations. And so that's why we saw the WHO Director General also praising China for the actions that it took. Did he take it too far? I think probably you could make that case. But equally, I think it's important to appreciate there's a very fine line that he's been trying to tread here. And perhaps some leeway should be acknowledged and given to him for that.
Are those international health regulations binding in international law? That was another question we had.
So the short answer is no. I've had this discussion many times with global health lawyers and international law experts more particularly. For me, you often have lawyers say, well, regulations aren't law, aren't a treaty. Whereas my view on this, and it is shared by some global health lawyers as well, is kind of if it looks like a treaty, smells like a treaty, it's probably a treaty. And there are certainly binding elements that governments are expected to and are obligated to comply with, such as notification of disease outbreaks or disease events, such as developing these core capacities. The big problem with the international health regulations, though, is that there's no penalties attached for when governments do the wrong thing. And so we've seen governments sort of ignore WHO advice in the past, and there's no consequence. A good example of that, so Australia was one of around 20 countries that was affected by pork export bans in 2009 as a result of the H1N1 influenza pandemic. Because you may recall that when that pandemic first started, WHO called it swine flu to avoid the risk it was going to get called the Mexican flu. And so they called it swine flu thinking, oh, well, that'll help avoid that risk. But what happened then was a whole bunch of countries put in place these pork and export bans. So Australia had to actually take it to the World Trade Organization to get compensation for those measures. There's no penalty under the IHR.
Other questions are what would a more collaborative, collective security approach to COVID-19 have looked like? Or I suppose, what new policies might the UN put in place learning from this?
Well, it's a really good question. The short answer is we don't really know right now. I think one of the big challenges, people have sort of speculated whether or not the WHO is going to survive this. I think the WHO will. I'm not convinced that the international health regulations will survive, at least in their current format. And there's been a lot of dissatisfaction with the IHR for a number of years now, for over 12 years with the new version. So whether or not this is then going to lead to a new framework trying to be developed, or a new treaty being developed, remains to be seen. I think probably what would have been good to see is that countries moved rapidly to start to assemble stockpiles of things like medical equipment and personal protective equipment, and really escalated global manufacturing capacity that everybody would be able to access. And instead, what we've seen has been sort of countries putting in place trade measures and trade protectionism, particularly around their PPE, so that they can hold on to it, even though their country may not be as severely affected as other countries at the moment. And that was the thing. It's kind of like, there conceivably could have been things that would have happened which would have helped. There's been a lot of criticism from Italy about the EU and their lack of assistance there. And I think that is fairly justified. And whether or not, we should have seen more effort being placed on trying to help countries out when they're first being hit with this, as opposed to everyone sort of then focusing internally.
And then what might the impact be if President Trump does go through his threat to withdraw funding from the WHO?
Yeah, good question. So at the moment, the United States provides around 25% of the WHO's operating budget. That's so WHO has two forms of funding. One of them is called assessed contributions, and the other one is voluntary contributions. Assessed contributions are what the UN system usually sees operating in by. So it's a calculation based on GDP and population, and you then there's a calculation made as to how much of the pie you have to pay. Because obviously the US is one of the world's strongest economies, they've had to pay the fair chunk, around 25% of that assessed contribution. But the US Congress has been very unhappy, and so they actually froze funding in the 1980s, and that assessed contribution has not increased in real terms since the 1980s. What the other pot of money that WHO has access to is voluntary contributions, and the US has obviously been a very big funder of other global health programs, but that's tied funding, so the WHO can't reallocate that. So if the US government withdraws funding from the WHO, there is no doubt the organisation will suffer. The organisation has already been on the verge of bankruptcy on a number of occasions. If he follows through with the threat, there will no doubt be that the WHO will end up in a precarious financial position. And then it will be up to the rest of the international community as whether or not they want to change the funding models and step in and fill the gap that the US has left. We can probably anticipate that China may. This is obviously a very key opportunity for China to, and many people are already aware of that fact, that China may use this to gain more sort of strength in the international system.
I'm keeping a weather eye on the clock because we do try and finish. I think we've probably got time for one more question because I'm conscious you've probably got a pile of tasks here. But we had a question about countries developing vaccines. Do you think, are multiple vaccines going to be developed out of all the work being done, or are we going to end up with one single one? Or how do you think that plays out?
I think, and just going back then, this is a good segue to that previous question about what would a collective security approach look like. In 2003, one of the key reasons why SARS ended up being dealt with within 4 months and halted was because we ended up with people leaving aside ego, and we had groups of scientists working all around the world on a 24-hour basis, sharing their data freely through virtual networks. And so that as one team went to bed, another team would start and pick up from that exact same spot. We haven't seen that in this instance. Instead, what we've seen is what's been described as an arms race for the vaccine. And that's been really regrettable because there's no doubt a huge duplication of effort as various different organisations supported by governments are trying to develop their own vaccine. When ultimately, arguably, what would have been the better approach would be that we develop that virtual network. Everyone is then able to piggyback on the developments of others, and we would have had that vaccine probably already developed now. And instead what we've got is a whole bunch of different organisations supported by governments in competition. So yes, we are likely to see now multiple different vaccine candidates come to trial. The challenge around that is that there will be some vaccines that conceivably will be more effective than others. Some vaccines may require 2 doses to confer immunity, others may require only 1. The big challenge once we have vaccine candidates is twofold. Firstly, conducting the human trials and how rapidly we're able to ensure the safety and efficacy of the vaccine. And then the big challenge, which isn't really talked about that much at the moment, is the vaccine, manufacturing enough of the vaccine in order to be able to distribute it. And obviously there's an issue there around price and cost as well. So is this going to be a vaccine which only people in high-income countries will get access to? Probably. Whether or not it's going to be made freely available to people in low-income countries, we haven't even started that discussion yet. And obviously, if you've got companies supported by the European Union or by the United States or even by Australia, you may very well see that they're going to want to see money coming back to them for that investment. So yes, this is something which realistically in the past, when we were looking at an influenza pandemic, we recognised that it would probably take somewhere between up to 2 years to have enough vaccines to be able to vaccinate the world's population.
Well, I think that it does bring us to the end, unfortunately, of our allotted time. It's always a sign of a great talk when we have multiple questions still waiting to be asked and answered. And of course, a topic like this, you're going to. Nice to think we'd end on an air of optimism, but I think we're still in uncharted waters, as people keep saying. But yeah, Adam, we really appreciate your time and explaining so clearly so many of these issues in a very complex and evolving situation. We wish you well, and to our whole audience, thank you very much for joining. Please all stay safe and well, and we'll see you next time. Adam, once again, from Melbourne, thank you very much indeed. Take care.
Thank you, and stay safe, everyone.